Hello, I'm Goisis, I'm an aesthetic surgeon from Milano. We have to plan the treatment of tomorrow. A minimal invasive treatment. It means that you will not suffer, you will not have pain, and we will discuss together about the result. So we will treat some area of your face, we will have a mirror. The mirror is my best assistant, and with my best assistant we will say, okay Mario, let's give me much lips, let's give me this kind of correction, we will work together in order to have the best result on you. So what we can do on your face? We can fill a little bit this part in order to correct the sagging of the face. We can increase a little bit, and in a natural way, the volume of your lips. And about your nose. About your nose, we can correct a little bit the shape of your nose. Do you agree with me?
Yes.
Because the tip of your nose is to be corrected, it has to be corrected a little bit. So we will increase the nasolabial angle, which is the angle between the lip, the upper lip, and the nose. So we will do this kind of effect with our fat. We will correct the dorsum. The dorsum will be more straight, and we will also work on this angle, which is the angle between the nose and the frontal area. We will increase a little bit that angle. Okay. And after that, we will fill a little bit the temporal area. And after that, we will improve a little bit your neck, and after that, we will work on your hand. And so we will feel a little bit your hand, because in this way, all the part of your face, of your neck, of your hand will be younger. In this way, you will be totally younger. Okay?
Yes.
So let's do the treatment, and it will take around 20-25 minutes. It will be performed under local anesthesia. It will be simple, but it will be very, very effective. So we have design all our program. We have not so much entry point. One entry point in order to fill the nasolabial folds, upper lip, lower lip, chin a little bit, and cheeks. This entry point in order to fill the lacrimal sulcus with Microfat and Nanofat. This entry point to fill the temporal area. And one single entry point on the tip of the nose in order to fill the dorsum, quite all the dorsum. We will not fill this area, which is called supratip. In this way, we will obtain a very natural result in correction of the nose, and from the same point, we will inject a little bit under the nose, some volume, in order to do this kind of elevation of the nose. So, not so much entry point means that usually we don't do any kind of hematomas. We discussed previously about hematomas. So it's a quite minimal invasive procedure. I have many patients who work in Milano, who has to go to La Scala Theatre in the evening, to do TV show and so on. So it's very common for me to do this treatment even when the patient has planned other kind of things, because usually we don't leave any signs of our treatment. For the neck, we will inject with a really small needle, the smallest needle that we can use. We will inject only nanofat and stromal vascular fraction. So we don't need to use the cannula, and that's why we do small injections like mesotherapy. For the hand, at the hand, single point of injection, very simple distribution of our soft filler in order to improve the quality of your hand in a very efficient, not painful, and simple way. So we want to treat on these patients the profile. So we want to work on these patients on the nose shape. We want to work on the nasofrontal angle. And we want to fill the upper lips. So that's the major program that we have with these patients. Despite of that, we will increase the temporal area, the temporal volume, and we will obtain a very, very natural result. To do it, we will use a minimal invasive treatment. We will inject Microfat and Nanofat on our patients in order to improve the shape of the face, and we will use a minimal invasive procedures. Our idea is to do a really minimal invasive treatment using a closed system in order to offer to our patient, may I have a 10cc syringe and a yellow needle, in order to offer to our patients a minimal invasive procedure. So the area of harvesting is the flank. In this case, we have some fat in the flank. I'm injecting the entry point with a yellow needle. May I have a white needle, thank you. I change the yellow needle with a white needle. And I'm changing the white needle with a single-use cannula. Thank you. Okay, we don't need it. So, I'm injecting my local anesthesia. It's Klein solution, standard Klein solution, which means 1 liter of saline with 800 milligrams of lidocaine, 1 milligram of epinephrine, and 40 milliequivalents of bicarbonate. I'm using a very small cannula, it's a 2 millimeters diameter cannula. And so, by using this cannula, I don't need a cannula for infiltration of local anesthesia. I use this cannula both for infiltration of local anesthesia, both for harvesting of fat. Okay. It's a single use, this one. We have a 10cc syringe. It's a single use. We have even a disposable one, but this one is single use. I'm doing now local anesthesia in the entry point. We will inject, we will fill the hand of our patients. And we will fill the face. Our standard entry point.
The patient is lying on the table. Is she lying flat on her back? It looked like she was rotated in the hips.
Yes, we have special drapes, which you also, in this way the patients can move freely. We do this treatment under local anesthesia. So the patient is on the flank, she can rotate now, and she will come back in normal position. We do some truncular anesthesia.
Don't you have any IV sedation?
Usually, no, but these patients, no. Ask some propofol, a little bit. Sincerely, I don't like. I like to speak with the patients because I'm Italian. I always like to speak. May I have another? And I like to show the result of the patients at the mirror. In this way, we can discuss about the result. Now, because of your sedation, you become a monster.
What is the concentration of the local anesthetics in the face? Is it the same?
Is it the same? Is it the same? I inject the tip of the nose. Now I'm injecting the nasal spine. And I'm injecting the temporal area. Sorry.
How much fat are you planning to take out of her?
Oh, I think 10, 15 cc, no more. I don't like to feel too much my patients. Now I'm harvesting the fat. I'm using the Vaclock syringe. It's a special syringe which allows me to maintain the negative pressure. And I'm applying a rotational movement. It's Vaclock. Is included in this kit. It's a closed kit I will show you. We try, with our system, to think about all the problems that can create problems to the fat and to avoid this. For example, before I've seen... yeah.
Any contraindication for this operation?
It's a general disease, anticoagulant therapy, these kind of things, of course.
Smoking?
With smoking, you will have, surely, more resorption of fat. Usually I propose to all of my patients not a single treatment, but I like to offer to my patients a 1-year protocol, so all the touch-up are included. In this way, even a smoker, after 3 or 4 treatments, we can have a quite good result. Of course, if a patient is not smoker, it's better. That's the...
Harvesting about 50 cc from this side.
Yeah.
You're going to harvest another 50 cc from the other side?
No, at the end, if we look at the syringe, the quantity of fat is not 50. We are harvesting around 20, 25 cc of fat, no more. You have to note that I never retract all the plunger of the syringe. Because creating 60 cc of negative pressure means to create too much negative pressure, means to destroy many fat cells. That is the system that we will use in order to wash and to filter the fat. It's very simple. We connect our syringe, we wash out the blood, we retract the plunger of our syringe. The syringe is automatically filled by saline, because we have an automatic system of single direction valves. We wait a little bit, the fat go up, of course. We wash out the fat. We wash again. The saline is automatically connected into the system. We have 2 filters. One filter is 200 micron. The second filter is 20 micron. The first filter entrapped into the system the fat. Okay. And the second filter entrapped into the system the stem cells. Okay. We can remove, this is oil. Can you push out? And red cells. May have another syringe filled by saline. Thank you. Okay. And here we are. We push out the blood. We push the fat against the filter. Okay, now what we will do? We will take from the space between the 2 filters stem cells, which are entrapped in the second filter. We will use a part of the fat in order to produce nanofat. Produce nanofat means to disrupt the fat. Can you see it? Yes. So, we will pass the fat 30 times between the 2 syringes. And we will add this nanofat with the stem cells which were entrapped in the filter. Okay, 30 times. And this is our enriched nanofat. We use it, and we use our microfat in order to fill the face of our patients. So, 2 products, one very rich of stem cells, the nanofat, and the other one, a good filler in order to fill the face of our patients. Okay. The 1 cc syringe. Perfect. We start our procedures with our microfat. Our filler.
When you transfer the fat to make the nanofat,
Yeah.
you emulsify the fat.
No.
What is the diameter of that transferring segment of the system?
200
You
micron.
can't have a too big hole if you want to have true. Yeah, but it didn't go through there when you did the nanofat, did it?
Yes, we did it. The first filter, this one, is 200 micron. It's a quite big filter. It allows the passage of stem cells and it stops fat cells. The second filter is 20 micron. It stops the stem cells. The stem cells during washing are entrapped in the second filter. That's why when we take stem cells from the space between the 2 filters, we collect the stem cells which were entrapped in the second filter and we add the stem cells to nanofat in order to have an enriched nanofat, in order not to lose the stem cells by washing. But when we do nanofat, when we create a nanofat, we destroy the fat between the 2 syringes and we pass through the first filter, which allows the passage of stem cells, but which stop the fibrotic tissue and allow us to inject with a small needle. I can show you the fat particles of microfat, which are very small, because we use a special cannula, which allows us to harvest very small fat particles. At the opposite, nanofat is an oil emulsion, we don't have fat particles. Because of we don't...
You can inject that with a 27 gauge needle.
Yeah, of course. With a 27 gauge needle, this one is 30 gauge really, but even with a 30 gauge needle, we can inject nanofat. For example, in the neck. Even very superficially, can you see it? Yeah. Because it's an oil emulsion, so we don't have problem.
You don't use a 1 milliliter syringe because the extrusion force is much larger in a 10 milliliter syringe. Don't you find it being difficult to get it up through a 10?
It's true, because I'm using a very small, yes, but because you asked me, and so I want to show you immediately, yes, but it's absolutely better. In fact, for Microfat, I'm using now 1 millimeter syringe. It's best, for our hand in particular. Okay, entry point modulus. Nasolabial folds. Maxillary projection. Malar projection.
And now you're injecting microfat.
Microfat, I'm creating volume. Upper lip. It has to be a very, very fast procedure. It has to be a procedure like injection of filler.
Is that the cannula that you use?
Yeah, 22 gauge cannula. Mental crease. Our patients, and we will discuss after with 3D comparison between the two, with Canfield system, with 3D examination, has a quite open facial angle, so we absolutely don't have to feel the chin. At the opposite, we have to feel a little bit the nasal spine. Now I'm correcting the nose. May I have a go with? Okay. From the tip of the nose, we will feel the dorsum. We have a quite narrow nasofrontal angle, so we have space to feel it. Okay.
We can't see if you're aspirating. We cannot see if you're aspirating before you inject.
I don't.
Is that something that concerns you?
No, I don't. I'm using a very long cannula. I'm starting from the midline. I'm using a blunt cannula, so I don't do it. Okay. Now I'm on the nasal spine. Okay. I look at my nose, and I think that I have to add a little bit more volume, perhaps. What do you think, Per?
I think it looks good, but I think there should be a little bit more up in the nation.
Okay. A little bit more here, yeah. Okay. And a little bit, I like to inject a little bit on the tip, yeah, in order to create a kind of supra tip. Okay. Okay. Yeah. I can feel a little bit of the upper lip more. What do you think?
Yeah, do you go into the mucosa then, or?
Yeah, I'm close to the mucosa. I'm the muscle. I try to be the muscle, but I'm close to the mucosa, posterior. Okay.
Don't you find that the fat injected in the lip is absorbed very high degree?
Of course it is. It's a very major absorption because we have a lot of movement, and so. Okay. So the most important steps are in harvesting, to try to harvest the fat quite superficially, because we have more stromal and vascular fraction. To not apply too much negative pressure, because it will destroy our fat. We have this book edited by Springer in publication in May, in which we try to compare different techniques of harvesting. So, harvesting is the first step. The second step is processing. To try to avoid exposure to air. To try to avoid too much pressure, like in centrifugation. And to preserve the major number of stem cells that we can. In this case, by using a double filter, we can have a good concentration of stem cells. And of course, during injection, it's important to not create too much dead space. And we can do it by injecting with a small cannula and creating this kind of tunneling. Okay. And other area that we have to do are the lacrimal area. For the lacrimal area, we will use the nanofat. I can use white like this. No, but okay. And the microfat. With the microfat, we will fill the green needle. Thank you. We will fill the area under the orbicularis muscle. So we are in a D plane. Here we are. So the cannula is in a D plane. May I have the syringe filled by nanofat with another cannula. And so we inject quite deeply. Okay. A small quantity, 0.2 cc. With nanofat, at the opposite, we inject very superficially. Because we are not creating volume, so we can inject very superficially at the level of the hypodermis. The nanofat allows us to have a very, very good improvement of the quality of the skin. And so we can use very superficial even in this case, in these small wrinkles that we have on the cheek of the patients. Very superficial injection, because I'm injecting nanofat. And very superficial injection on the cheek of this side.
What do you mean by superficial?
It means subcutaneously. Usually I try to inject our microfat into the muscle a little bit deeper. For example,
When you inject along the tear trough in the palpebral malar groove, and
I'm injecting
basically no subcutaneous space. So you basically underneath the orbicularis, or where do you inject the nanofat?
in the lacrimal area. I'm under the cutis. Yeah, I'm subdermal. So I can see the tip of the cannula because, as you say, we have a very, very reduced thickness skin, 0.5 millimeters, and we don't have too much subcutaneous. We don't have subcutaneous tissue, so I'm very superficial with nanofat. With microfat, I'm deeper. For example, now I'm injecting microfat, and I'm injecting nanofat because I previously injected nanofat. Now I'm injecting microfat. I touch the bone. I'm close to the bone. I'm under the orbicularis muscle. I inject a small quantity. Okay, perfect. After that, we have to fill. The last things that we have to fill are the temporal area.
Okay.
Are you okay? Okay, great. We are finishing. Okay. Some injection in the temporal area. Inject small quantity. Okay, one. And two on this area. Okay, great. And the last 1 cc, I ask the assistance of anesthesiologist for the last hand, so we can disinfect the last hand, the second hand. Yeah.
So Mario, could you tell us a little bit about your post-operative regime? Do you do something specific to these patients? Do you give them any medication to avoid swelling? Do you treat anything for bruises, or do you put cooling on them? Or
Yes, we can put ice, we can put cooling. Usually I give to my patients 3 days of antibiotics, like azithromycin, very light antibiotic prescription. And I never suggest to take corticosteroid, because it's demonstrated that corticosteroid reduce the survival of fat. And painkiller, if they need, of course, usually they don't, but good.
So that's a relatively straightforward and simple procedure for the patient. And you say to them that they usually need another injection in what time frame when you
Usually after 4 months after the procedures. Stand up. Okay, so can we do a 3D image? If you want to compare the pre and the post, we can do even a simple video, like a simple photo like this. We can see the difference between pre and post. We should even compare directly with a photo pre our facial profile, which is better. So the main advantage of this technique is that, yeah, the nose, I think it's okay, the nose, yeah. We work mainly in this area with nanofat because we don't want to add too much volume to the cheek. It should be natural. We work mainly with microfat in this area. And so that's what we can obtain. The lips is corrected in a good way, I think. We didn't add volume to the chin, of course, but we work on the mental crease in order to improve it. With small defect, in some cases, fat is a good option because with filler, we have the problem to have to repeat the treatment a lot of time. With surgery, we have to do a major intervention. With this one, it's like a good solution because the result after treatment is really very, very stable. Even because we have a good fat survival in the nose because we don't have so much movement, so a better survival than in the lips. And so it could be a very, very good solution for us. Thank you for your kind invitation, and I'm very proud to be here with so much great surgeon, all great surgeons today except me. So I thank you very much for your kind invitation.